this week, we have this pleasure of listening to two of our relatively new academics in the department. And they joined in the last 1 year or so. Yes, so they are, they will introduce themselves. And so you'll hear about their work and their background and so on. I just want to say that, so they will give a talk, and then each of their talk will be followed by Q&A. And after this hour of 2 talks, we will have a breakout virtual wine and cheese session afterward, and we will distribute to go into virtual rooms to talk to the speakers. Please enter your questions into the chat box, which I will pay attention to and come back to during the Q&A session as a moderator. And I think that's it. So first speaker is Parry. Please take it away, Parry. Thank you for speaking today.
Thank you, Naomi, for inviting me to speak. So I'm Parry Hashemi, and I joined about a year ago as a senior lecturer. So I'm just going to talk to you about a relatively new project that we've been doing that I'm really excited about. Some of you have heard some parts of this story already, but I've got some new stuff here that I think I'm very excited about. So I'll tell you the story. Okay, so if you know me and you know what my lab does, we're interested in mental illnesses, and we're interested in studying the fundamentals of mental illness. I'm going to start the talk with this quote from Sylvia Plath's bell jar. Wherever I sat, on the deck of a ship or at a street cafe in Paris or Bangkok, I would be sitting under the same glass bell jar, stewing in my own sour air. I always start my talks with really sort of morbid quotes like this, but I think I like to set the stage because mental illnesses are really no joke. They constitute the biggest disability burden in the world, and this quote really sort of embodies one of the most sort of devastating things to me about mental illness, and that is that it's invisible and it's silent and it follows you around. So if you've read this book, you sort of understand the real power of this quote in terms of something that devastates you but nobody else can see. We focus on depression because depression is the single most largest health issue in the world. The WHO Health Organization estimates that 300 million people are diagnosed with depression, and that's probably only a fraction of people that actually suffer from it. And just to put that number in perspective for you, 100 million people in the world are diagnosed with cancer of any type. So at least 3 times as many people are diagnosed with depression. It is difficult to diagnose. It's up to the patient to describe their own symptoms, and it's up to a healthcare practitioner to be, sympathetic to the symptoms because there is no chemical test for depression. Despite the difficulties in diagnosing, a huge number of people are prescribed antidepressants. The numbers are different. I think in the States it's something like 1 in 5 people, and in England it's 1 in 8 people. That's a huge amount of people. They don't work for the majority of patients that take them. They have, issues with dosage and different types, and you often have to go back several times to the doctor to get the type and dosage adjusted. They have this funky onset of action where you have to take them for several weeks before they have clinical efficacy, before they may have clinical efficacy, and during that time, people often feel much worse before they feel better. And I would say about 15 years ago, Big Pharma pretty much completely toned down their drug discovery efforts because we don't really understand the chemistry of depression, and the current drugs don't work very well. It's very, very difficult to screen novel agents. So we sort of stopped looking for new agents. So, sort of put this together, this is a really big problem. And I think you'll all agree with me now that the current situation is going to just mean that it gets worse. So why does this situation exist? The issue is that we don't know what's going wrong in the brain during depression on a chemical, fundamental level. And there's been different theories that have come in and out of fashion. I'm going to talk to you about one of them. This is the most popular one. This is called the monoamine theory of depression. So what you're seeing here is 2 brain cells communicating, 2 neurons. This is a presynaptic neuron. This is a postsynaptic neuron. This is sort of the basis of chemical communication in the brain. It's called neurotransmission. This theory implicates primarily a neurotransmitter called serotonin. So this presynaptic neuron will send a message to the postsynaptic neuron, and that message is serotonin. That's the neurotransmitter. Under normal circumstances, this cell releases serotonin. It acts on these postsynaptic proteins and relays its message. The theory says that for some reason, during depression, the serotonin levels are lower in the synapse, and that by administering the selective serotonin reuptake inhibitors, so this is a very popular class of antidepressants, which inhibit the inactivation of serotonin once it's been released into the cell, that you can increase the serotonin levels. So this theory has been around since, the 60s, but really no one's known for sure if this is the situation, despite the fact that the drugs are so widely. So a couple of issues and prospects that we've been looking at in my lab, and some of the things I'll talk to you about today. We really care about diagnosing depression in the same way that we could diagnose other diseases, say diseases of the body like cancer. And this necessitates a hypothesis like that monoamine hypothesis that I showed you. So we sort of have to come up with a hypothesis. We have to be able to measure it chemically. And if you do it in animals, which is what most of the preclinical work is, how do you translate that into humans? Once we figure out what's wrong, can we work on bettering the treatments? And in that respect, if we start with those SSRIs, we need to look at that time frame issue that I talked about in several weeks. We need to figure out why they don't work for the majority of patients, and can we make them work better? And then again, if we could do that in animals, how translatable is that to humans? And then finally, this issue of drug screening. If we figure out what's wrong, if we figure out how to fix it, then maybe we can reinvigorate interest from pharmaceutical companies in creating new compounds. And that the system needs to be out of the body, ideally, because it wants to be high throughput and again translatable, and the holy grail of that is personalized medicine. So I'm going to primarily talk to you today about sort of a diagnostic aspect, a little bit about treatment, and then I'm going to touch on screening if I get time. Okay, so what we've done over the past, I would say, decade or so is created tools. So, the big issue of us not being able to define the chemistry of the brain is the lack of tools that can really measure meaningful chemistry in the brain. It's difficult because brain cells are very, very delicate, they're intricate, the chemistry is extremely fast, and chemicals look the same as each other. We've developed the method. I'm not going to talk about it too much today because I want to show you the results, but the method is based on an implantable electrode. This goes direct into brain tissue. It's made out of carbon fibers, and it makes two types of measurements of serotonin. We started with serotonin because we wanted to test that monoamine theory. There's two types of sort of transmission that we're interested in. If you look at these red balls, this is supposed to sort of signify a steady state, resting basal level of serotonin that just sort of is there, and maybe it changes slowly with time based on sort of more global changes in the brain. And then there are sort of these faster responses. I'm going to call that phasic or evoked responses. And these will sort of control more urgent aspects of neurotransmission. So this will be a burst of activity, a burst of serotonin. And to measure that, we need much faster time resolution within seconds, basically. So like I said, I'm not going to talk too much about the methods, but the crux of my research program has been to develop these methods. They didn't exist, and we developed them. It took us a long time, and we've been really the first to use them to ask some really basic questions about serotonin's roles in depression. Just to give you a quick overview of what they look like, because I'm going to show you some data, but I won't spend too much time on it, like I said. And if you have questions, please drop me emails. This is a scanning electron micrograph of the carbon fiber microelectrode. It goes direct into brain tissue. It's so small, it's about 7 microns in diameter, that it really doesn't damage the tissue. And the work I'm going to show you today is in anesthetized animals, but the animals can equally be awake and walking around without the electrode really impacting their behavior or their or creating damage. So it's a sort of a complicated electrochemical scheme that we apply to the electrode, and it essentially allows us to get a direct signal from a serotonin molecule that looks like this. This is called a cyclic photomegram. This is the physiological model. So this is a sagittal representation of a mouse brain. His eyes would be here, his tail would be here. And we stimulate the release of serotonin using a stimulating electrode and stimulating axons, and then we put that carbon fiber into a region of interest. A lot of the work I'm going to show you today is in an area called the hippocampus, the CA2 region of the hippocampus. And then this data looks like this. You have a stimulation here, so nothing much is happening. You have a stimulation, and then the serotonin levels go up, and at the end of the stimulation, they come down. This mimics that sort of faster phasic evoked response. We can model this with this equation down here, and basically it tells us how the serotonin evoked fast serotonin signal is controlled as a function of autoreceptors, reuptake mechanisms, and then we're going to add to this later things like synthesis and metabolism. The other technique that we spent years developing is called fast controlled absorption voltammetry. It uses the same electrode, very much the same principles, but essentially the electrochemical scheme allows for quantification of that rather than the sort of fast evoked response. It lets us get at an ambient or basal response. And it does that by holding the electrode potential. So here we apply a waveform to our electrode at a very high frequency. We stop the waveform application. We let the serotonin come into equilibrium with the electrode, and then we turn the waveform back on and quantify it. And so what you're seeing here is that same CV. It sort of tells us what we're looking at, but here what the kind of data you're going to look at are points in time rather than the sort of release and reuptake. We're going to maybe have 1 point a minute, and that tells us the basal or the ambient measurement. Okay, so that's like 15 years of work in 2 slides, but there we go. Now we're going to apply this technique to that, the big question, right? If we have a testable hypothesis, the monoamine hypothesis, and it basically says that serotonin changes during depression. Like I said, this has been around since the 60s, but no one's really been able to say yay or nay on it. So we just decided to test it. And this would provide the basis for a diagnostic test, if you can think about it that way, because it's a hypothesis, we can test it. Okay. So we do a behavioral paradigm where we take mice and we expose them to chronic stress. This is relatively well known. Well, this is well known in the field to create depression phenotypes. I'm going to come back to that in a second. But we did this on a cohort of mice, or several cohorts of mice. And what I'm showing you here is data from, I don't know, maybe 20, 30 mice. I don't know exactly how many mice my students used here, but you're seeing that fast evoked response where we stimulate serotonin release. And there is literally no difference at all between mice that have been chronically stressed in terms of their serotonin release and reuptake profiles, and the CMS is the name for that stress paradigm, chronic mild stress, basically. So we were see this, and by the way, these are the sort of representations of the raw data, just to let you know what it looks like, and these are the signals. We were extremely disappointed to see this because we spent a long time developing the probes and a long time learning and implementing the behaviors, and we saw absolute perfect agreement before and after. I'm glad we didn't stop there, because we then went and in these mice, we measured that sort of resting steady state level, like that I talked to you about with a secondary technique. And there we did see a big change. So in terms of, let's go up here, this is testing the functionality of the system. So this is telling us that the neurons release and reuptake serotonin. Nothing in that respect has changed, but how much serotonin is available in the extracellular space is dramatically lower in the mice that have been stressed versus the control mice. And this is raw data that accompanies this result. So this was really exciting. Now, another thing I want to mention here, the chronic mild stress paradigm, and all behavioral paradigms, you expose the animals to stress and they develop depression phenotypes, but only some of them develop depression phenotypes. This is well accepted. The idea is that some of them are resilient to the stress and they don't get the depression phenotypes. And there's been a lot of literature on this. So, you know, when we've done it in our hands, something like 50 to 60% of the animals develop depression phenotypes. But what I want to show you here is that despite that, those 50%, every single animal that underwent the stress paradigm had less serotonin than the control counterparts. So the chemistry here is way more robust in signifying stress than is the animal behavior. And I think that's a really key message that we found here. Here we did a really exciting collaboration with Professor Klopath's lab in the department, and I'm going to do my very best to describe their results, but I apologize because it's quite complicated and involves a lot of modeling. Her postdoc, Melissa Renault, was a brilliant, very, very smart person, looked at our data and went and read all the literature and started doing some modeling for us. So the first thing they did is they took this data and they did a k-means clustering test, which is a machine learning algorithm that basically takes some training data and then looks at test data with the models that they've trained. And they found using our data that the data from these mice could be really well clustered into two groups. One would be stress and one would be healthy. So you've got sort of the black marks here being the stressed guys, the blue marks here being the healthy guys. And importantly, when we used this algorithm to look at our test data, the test data in over 90% of the time got the animals right in terms of whether they've been stressed or not. So that's really key because it looks like serotonin level alone can tell us whether that animal has been exposed to stress or not. As there's a huge, sort of big leap forward from the 60s where they sort of, implied this and then no one could show it. And now we've not only shown it in terms of sort of the 50% behavior, we've shown it in terms of the 100% chemistry and made a simple model to be able to predict. Okay, so this was exciting. But we didn't want to stop there because, like I said, look, the serotonin system regains its functionality. So what has made the serotonin levels drop? All right. And I want to speed up a little bit. I apologize, but I want to get through the whole story and I know I'm time limited. So something has changed to make the serotonin levels drop. And we don't think it's serotonin itself or the functionality of the system. If you guys follow the depression literature or frankly any sort of health literature these days, this idea of inflammation is extremely hot right now. And in terms of psychiatric illnesses, neuroinflammation is pretty much synonymous with psychiatric illnesses. Let me talk about inflammation for a second. Inflammation talks about your body's immune reaction to something, anything. It's a general blanket term that describes, an immune response. And when it's neuroinflammation, it's your brain's immune response. This is a relatively complicated slide, but what I wanted to show you here is that if you have, this is a person who's undergoing some sort of inflammation, whether it's an infection, it's an allergy, it's trauma, it's ingestion of a toxic metabolite, they are put into motion several biochemical cascades that involve cytokines and all this kind of stuff. But essentially, a inflammation of the body can translate into an inflammation of the brain, a neuroinflammation. So there's a real link between the brain and the body inflammation. So this was very interesting because people know, of course, that during stress, there is quite significant inflammation, bodily inflammation, and as such, neuroinflammation. So we sort of wanted to test this a little bit. And here's some data that I think is really neat. So what I'm showing you here is that ambient basal data from the stress mice. So these are ones in pink. And this is a cohort of this is a different cohort of mice that have been stressed. So their ambient levels are at about 45 nanomolar and control levels are around about 60. Okay, so we know they're lower. And what I'm showing you here is a measurement every minute in these mice. This is the experiment that I'm sort of excited. Well, I'm quite excited about. Here we have another. These are just normal control mice, anesthetized, and we start making serotonin measurements once a minute, and these are just at the level that they should be. At this point here, we give our stress guys just saline, nothing much happens, we don't expect it to, but we give these guys here, these control guys, we give them something called LPS. This is a protein found in the outer membrane of gram-negative bacteria and is known to create a very rapid, robust inflammation response in the body. As a molecule, it itself doesn't go into the blood-brain barrier because it's too big, but inflammation. And you can see, within 5 minutes, the serotonin levels in the brain start to drop. And after about an hour, they get to the chronic inflammation guy. So we've created acute and a chronic inflammation, body inflammation in mice, and we see the effects on serotonin in the brain. And in the case of the acute, in a very, very fast, rapid response. So this is interesting. Okay, so we've got inflammation driving serotonin levels down. Why? Here we sort of started getting interested in histamine. Histamine, why did we get interested in histamine? Well, histamine is known to mediate inflammation in the body. That's no secret. If any of you suffer from allergies, I'm sure you take antihistamines and they are effective. We know that mast cells contain histamine, and they release it in response to inflammation, whether it's local or whether it's more general, and it mediates the inflammatory response. We also know there's lots of histamine in the brain, and in the brain it's also contained in the brain's immune cells, and in the brain it also acts as a neurotransmitter, but nobody really knows what histamine is doing in terms of the immune response in the brain. So that's what sort of really got us interested in histamine. A really brilliant graduate student of mine developed a method with our techniques to be able to measure histamine and serotonin simultaneously. So what I'm showing you here is, again, raw data. I won't go into interpretation of these. It takes a little too long, but long story short, again, this is several years of work. Srimal, my graduate student, basically figured out in a brain region how to measure serotonin and histamine simultaneously, and he elicited histamine release with that fast measurement, the FSTV that I talked to you about. And he showed that when he elicited histamine release, there was an instant and concurrent reduction in the levels of serotonin. So you have this bimodal response, and in this paper we showed that this was mediated via inhibitory H3 heteroreceptors on serotonin terminals. So these are histamine receptors on serotonin terminals that basically tell the serotonin neuron to shut off. So this is under normal circumstance. We're eliciting histamine release and we're getting an inhibition of serotonin. This is just the system at rest, but this actually really got us very interested because the pieces of the puzzle start coming together now. Histamine inhibits serotonin release. Histamine is involved in mediating inflammation response. So is histamine involved in mediating the brain's immune response. So with Melissa from Dr. Klopath's lab, they did some modeling for us, which is really cool. So the first thing they did is they went through our experimental data and they went through the literature, and they came up with a simple model that incorporates two aspects of how histamine and serotonin might be modulating each other. I just showed you experimental evidence that histamine negatively modulates serotonin. Okay, so that's this modulation here. And in the literature, actually, we'll found lots of papers that show that serotonin positively modulates histamine. So you sort of have this bi-directional response that Melissa described with these two equations, and they're relatively simple equations. That the H and S are the concentrations of serotonin and histamine. Tau H and tau S are the clearance of serotonin and histamine. And then IH and IS are the ambient basal levels, and then you've got these coefficients alpha and beta here that basically allow you to change the strengths of the parameters here. So here's the model. The next thing that they did is they parameterized the model here on the left by doing a null line analysis. And what this is showing us, so this blue line here is the S null line, and the serotonin null line, and the orange lines here are the H null lines, the histamine null lines. And this is basically sort of looking at discrete moments in time where the rate of change of serotonin is 0, and the same for histamine. And where these lines meet is basically where the system is at steady state. So that corresponds to the experimental data that I showed you where we elicited histamine release and we had this reduction in serotonin. So that's one steady state of the system. This is another steady state of the system. They did this modeling based on some prior data of ours where we changed stimulation strength and saw the relationship between serotonin and histamine. And this model absolutely beautifully lines up with experimental data. It's absolutely gorgeous. So this is basically showing the dependence of serotonin and histamine via the model and then comparing it to the experimental data. And the idea here, like I is that the histamine releases histamine onto a serotonin neuron and inhibits it via the H3 receptors. But if during stress and during inflammation there is more histamine, which we're sort of hypothesizing now because of the link between histamine and inflammation, there's going to be less serotonin in those stress guys as a consequence of that increased histamine. And so that's what the model sort of told us. And we went and we did the experiment. And sure enough, this is exactly what we found. So in our stress guys, this is the raw data. In our stress guys, we have the control scenario. And then the stress guys have more histamine, releasable histamine than the control guys. So that's a really beautiful example of how modeling sort of suggested an experiment and suggested a way for us to test why serotonin was low. Okay, so that's cool. Serotonin is low in the stress guys because histamine is high, but so we have the sort of break the building blocks for a diagnostic test. But what really we can do from there is to go and think a little bit about treatment now. So the next thing Melissa did is she went through our behavioral data. So remember I said 50% of the animals have behavioral phenotypes of depression. And she looked at the severity of that behavioral phenotype versus the serotonin level. And she found a relationship. So the more severely depressed the animals were, the lower their serotonin levels were. So she utilized that relationship to come up with something that we're going to call the stress index, or stress I, basically. The higher the stress index in those animals, the more severe their behavioral phenotypes were, basically. And so she has a stress index that basically is this index of not exactly of depression, but of stress in those animals. And then what she did is she took the model and she did a sensitivity analysis, and she changed the different parameters in the model and just saw what would happen to stress I within the model. And so you can sort of see it's difficult to see, but what she's showing here, actually, interestingly, is that by changing the parameters that correspond to histamine, you get more of a change in stress I. So histamine seems to be even more important here than serotonin. And equally in the stress situation here, the biggest change in stress I that we get is, let's move this up, is when we change a histaminergic parameter. Okay, so then we asked the model, all right, so knowing that and knowing the relationship to serotonin, what can we do then, sort of pharmacologically, going back to that treatment idea, what may we be able to do to help, restore serotonin levels under stress or under depression? So this is an experiment that the model suggested. All right, so let me just take you through it, and then I'm going to show you that we did this experiment. So this is an experiment where we measure serotonin once a minute, theoretically, with our experimental techniques. And so here we have a control set of animals, or a control model, which is around the 60 mark. That's what we had found before. And at this point in time, after about 30 minutes, we give saline. We don't expect anything to happen. Concomitantly, we've got the CMS, the stress guys. We know that they have less serotonin to begin with. We measured that. So we're going to basically do the same. We wait 30 minutes and we give these guys, now both of them, will give them a SIT is an example of a popular serotonin, an SSRI, serotonin reuptake, selective serotonin reuptake inhibitor. And to the control guys, the model says that their serotonin levels should go up, which is reasonable, right? Because this is antidepressant that inhibits the degradation of serotonin. The model says that the serotonin levels will also go up in the stress guys, but of course you can see that we don't get them to the levels of the control guys, right? And that's really what we want to do. So the model tells us that to achieve that, we should also target histamine. And a good way to do it is by targeting histamine synthesis inhibition rather than histamine receptors. Is a really good reason for that. And I'll get to that. And we're going to do this. So experimentally, we're going to do this with an agent called FMH. I'll get to that in a minute. But the model says if we do that to our stress guys, go after serotonin and go after histamine, we'll be able to get the serotonin levels back up to sort of a range where we'd expect to see the control guys. So we did the experiment, and this is super, super exciting because the experiment looks just like the model. These are now 6 animals or 8 animals in each cohort. Here are control guys. We give them saline. We wait, nothing much happens. We give them this SSRI, and the serotonin levels start to go up. We have a group of stressed animals. We give them saline, nothing much happens. We give them the SSRI, and you see the serotonin levels also start to go up. But of course, because they start at a lower level, we don't get the levels to get back up to the control guys. In a secondary cohort of stressed animals, we give saline, nothing much happens. We give now the escitalopram plus FMH, which is an agent that is a suicide inhibitor of histamine, of the enzyme that creates histamine in vesicles, and you can see very excitingly now that we can get the levels of serotonin from the stress guys right back up to the control guys. So here is another beautiful example of how a model has informed our experiments, and the experiments agree with the model. Okay, so there's more to this story, but I don't have time to tell you about it. But what I think is really exciting is that we have the building blocks to be able to diagnose. We've done it in stress, we've done it in different inflammation models. Histamine and serotonin are telling us something really important. And that allowed us to go to sort of look at treatments. We looked at maybe the variability. It could be as a function of histamine, and we figured out how to pharmacologically target histamine to be able to counteract that. I have a whole story about the time frame, which I don't have time to tell you, and I have a whole other story about the translatability aspect. If I have 2 minutes, I'm just going to quickly review on that. So what I've talked to you about is in animals, which is great. And I've talked about, opening the brain and putting a probe in it, which is also great. But, you're never going to volunteer to have that done to get a diagnosis of depression. At least I hope you wouldn't volunteer to have that done. So while this is a really interesting approach in animals, where does that leave us for human work? We're looking at a lot of different ways to be able to translate these findings into humans. And so one of the things that I really am excited about talking to you about is I'm going to touch on this sort of screening antidepressant compounds. If we have a focus on serotonin and histamine, and we know now how to get them to behave to reverse the lowered histamine level, is there a way we can test them outside the body? So this is work that we've done recently. The paper's under review. I'm very excited about it. We take human-derived stem cells and we turn them into serotonin neurons with some collaborators in Germany that know how to do this. This is the thing that they've been working on for several years. So this is a slide that basically characterizes these cells in terms of all the serotonergic machinery that they need to have to be considered serotonergic cells from the pre-differentiation stage. So I won't really go into it, but take my word for it that they look like serotonin neurons. And so we went over and we did this exciting work where we showed that essentially using our techniques, we could get the cells to also release and reuptake serotonin. So this is release and reuptake from the stem cells versus in vivo. Sure, the in vivo work is much more beautiful, but you can see the patterns emerging in the stem cells. And here we're showing that the stem cells are sensitive to stimulation strength and tryptophan, precursor for serotonin. So basically they do a lot of the things that the in vivo cells do. So this work is basically where I want to take this next. I want to start looking at these stem cells and seeing whether we can use them to tell us something about the efficacy of the drugs outside of the body. And going back to our issues and prospects slide, where is that now? Sorry. Don't mean to give you whiplash. Here we go. Going back to our issues and prospects slides, this is really the magic combination needed for an in vitro translatable high throughput system, which would truly be personalized, because these are stem cells that can be taken from themselves. Okay, so that's all I have to say. I'm just gonna, whip through these slides again. Apologies. And settle on my group slide, which we can't get together for a group photo, so this we'll have to do for now. But there's a lot of people that contributed to this work, and I've left out some of the more recent graduate students that did the work. But yeah, that's all I had to say, and thank you so much for your attention. And I don't know if we have time for questions, but I would happily answer them if we do.
Thank you so much, Parry. Yes, the time is a little bit tight, and there hasn't been any questions written into the chat box so far. Are there some questions that you want to raise a hands? Then we can have maybe time for one or two. But if there's no urgent questions that anybody has at the moment, perhaps you can ask your questions directly to Parry in that virtual wine and cheese session after the hour. If that's all right, could we perhaps move on to the second talk of the day by Yap Choon Hwai, and he is a new academic in the department. Yes, who started in July during the Yes. So yeah, thank you very much for giving a talk today.
Thank you for the exciting talk, Parry. Yeah, so I'm going to share my screen. I'm going to switch gear a bit onto the mechanics from. Is my slides showing on your screen? Someone? Yes. Okay. Yeah. Good. Yes. Right. So yeah. So we're going to switch gear into the biomechanics. So my name is Yap, and I've just joined the department actually just in July. And before this, I was actually at the National University of Singapore and was there for a number of years, where we laid down some of the foundation that we needed to do what we wanted for the fetal and embryonic hearts. So here, and what we are doing is to study the biomechanics of it. And the reason for that is that we are fascinated by how the heart forms from the embryonic stage. It's a very complex process, that starts with a little pool of blood, and it grows into a tube. It folds onto itself, joins back to itself. It grows a septum to divide it into the left-right axis. And from the beginning to the end, there's a tremendous amount of growth, from something really very small, a few cells, till when it's actually like a fully grown, very complex structure. And what is also equally interesting to us was that there are experiments in these small animal embryos where they just kind of mess up the flow, the mechanics of it by tying up the left atrium maybe, or injecting beads into the heart. And through that process, they were able to disrupt the normal physiological biomechanics. And then they actually saw these hearts become malformed after that. So kind of implying that this disruption of the normal biomechanical force stimuli actually causes heart to be malformed. Like, if you have the tie up the left atria of the chick embryo, then you get a hypoplastic left heart morphology. Or if you inject a bead to block flow in the zebrafish embryonic heart, then eventually these hearts may even stop having a lumen in the middle. Or for the silent heart model, where they kind of knock out the beating of the ventricle, these hearts actually do not form the precursor cells to valves. So what is the role of these mechanical forces in the proper and effective heart development? And we feel that is an interesting basic science question. And go strong, then you get malformation. Actually, a substantial number of pregnancies, and you can have a variety of different forms. You can have things like the TOF, which is a combination of 4 different defects in there, or you can have the HLHS, the hypoplastic left heart syndrome, which is where the left heart is born too small to be functional, or you can have a number of others. And in fact, we here are trying to understand, right, how we get these malformations. And we think that you actually need these normal biomechanical forces to stimulate the heart to grow in the right way. Then you get the normal anatomy. But because of genetic or other kind of problems, you get abnormal biomechanical forces during gestation. And then the heart grows and remodels towards the wrong set of mechanical forces, and then you'll be growing into the wrong shape, which then is the congenital malformation. And so we are interested to figure out how the mechanics affects this outcome. Because if we understand that well, we can also help a physician intervene in these fetuses to rescue the biomechanics environment to the proper one, so that then we can coax positive growth and remodeling, so we can rescue the anatomy and reduce mortality and morbidity. And in fact, that's not fairy tale, or that's not in the future, because that's actually happening even today. It's really new, but it's been showing very good promise. And there's only a few different fetal heart intervention procedures tried to date. But one of them is, for example, is a balloon aortic valvuloplasty. So for a heart that is threatening to become a HLHS with the small left heart phenotype at birth. And some of it is because there's an obstruction at the aortic outflow that disrupts the normal biomechanical environment of the heart. And that causes the heart to grow poorly. And then by birth, it will be too small. And that's where you have the HLHS, the hypoplastic heart at birth. And so physicians can do valvuloplasty. So by using catheter-based, minimally invasive methods, for example, you can stick a needle all the way through the mother into the baby's heart. And then you can use a balloon catheter to kind of expand, relieve that obstruction. And then from that point, then that left ventricle would have better biomechanics environment for the rest of its gestation, and grow up to be a normal biventricular heart at birth instead of just being a single ventricular heart. In fact, this type of procedure has been, improves with experience, and the success rate can be up to 90%, and it's been shown to be able to improve the rate of biventricular birth as opposed to single ventricular birth from 26 to 28% to about 60 to 70%. But it's not perfect, and there's a lot of things that we still don't understand. Why is it that in some cases it doesn't work? And why does it work in other cases? And how can we make this even better? What are the different angles to it that we can tweak, to improve the outcomes? So to us, it's a very important clinical question to be able to understand the biomechanics environment of these fetal hearts, understand these biomechanics effects on the outcomes and its growth. And then if we can predict these outcomes, then we can help the doctors select patients more accurately. So you don't, cause unnecessary risk to patients that are not going to respond anyway. And you try to find everybody that can respond to it so that you can help them get better, So with that in mind, so then we set out to try to understand, what is the biomechanics in this fetal heart, and until we were there, really there's not much work done in that very new area. And our approach to that so far has always been, trying to collect those images, from the clinic, and then we try to reconstruct it and track its motion, and then we model it either both the fluid mechanics of these hearts as well as the tissue mechanics of the hearts. We've done that for actually a whole bunch of different subjects, including humans and also animal models. So here's an example of what kind of images that you would get from the clinic. So this is 3 orthogonal planes, right? This is 4D ultrasound, so it's volumes over time. So we get these images, and because in the fetal heart you cannot use X-ray because you can expose the fetus to radiation, and then MRI is just not suitable for the fetus. You cannot measure the heart rate, and the resolution is quite small. So we had to fight the noise that we find from these images. So physiology and mechanics. So we've got this motion tracking algorithm, which you can see works well here. We've also got methods to clean up the noise via compounding and other methods. And then we are also working on a method to automatically segment this heart so that we can reduce our the time that we need to reach where we want to. And then we went in there to look at normal hearts and try to understand what kind of mechanics is there. So when we study the disease ones, we can compare it to these normal hearts. And this is some examples of the fluid mechanics that we have reviewed from the normal fetal left ventricle and the right ventricle. And they all kind of look similar in the sense that they have 2 vortex strings that emanates into the heart corresponding to the E and A wave of the heart. And they kind of interact with each other, and then they get ejected. And these vortex strings are the primary mechanism by which they can cause high wall shear stresses to the inner lining of the heart. And these wall shear stresses, shear stresses are considered to be stimuli for growth and other mechanobiology, in the embryonic and the fetal heart. So, and then we kind of look at the right heart more closely, and we kind of discovered that it actually has a wave-like motion. So in the literature, people have known that the right heart in some adults, in dogs, and some children kind of have a wave-like motion. It would contract first at the inlet and contract later at the outlets. But there's no data for the human fetuses. So we looked into that a bit, and we also found that there is actually a contraction wave. So what does it mean, right? Why is there a wave? So through our simulation, we were able to find that actually if the wave moves forward from the inlet to the outlet, then we actually save some energy needed for ejection. Sorry about that. Right. But if the wave is actually backwards, the outlet to the inlet, then you kind of you need to waste more energy to eject blood out of the heart. And it's kind of like squeezing toothpaste, right? So if you want to squeeze toothpaste out of the tube, you kind of squeeze from the far end first, right? So then it's easier and you take less energy to squeeze it out. But if you squeeze at the near end first, then you're not going to get much out. It takes more energy. So we think that this may be kind of like an adaptation of the heart to save energy as it functions. And then we have also used this technique to kind of look at some malformed hearts. And the first one that we looked at was the TOAB, or the tetralogy of fellow hearts. And here you have a combination of 4 different problems. You have the septal defect, the hole in the heart. You've got the stenotic outflow. You've got a thick wall on the right ventricle, and the aorta is in the middle instead of on the left. And so here we also try to understand what's the flow mechanics there and whether you can account for some of those malformations. What we saw here was that there was a lot of inflow coming in to the right ventricle, more than its size or its stroke volume could handle. And as a result, you have very violent, high shear environment there, where there's a lot of interaction between the blood and the wall. So then we also saw that for these fetuses, that have this TOF problem, the right ventricle was already thickening, even before birth. And so we think that there's a chance that this high washer stresses may be the cause, because typically a cardiologist would think that this because of high pressure that the heart wall would thicken. But in our case, our simulations have shown us that the pressure between the left and the right ventricle actually are quite similar because of the communication through the septal defect, the hole in the heart. So that rules out kind of like the high pressure being the cause of this thick walls. Now, the mechanics is supposed to affect anything in their growth and remodeling. The only thing that we can see that the change here was the washer stress and not the pressure. So, but of course, that's something that we want to investigate further. So then we are also moving into this hypoplastic left heart syndrome and trying to understand those interventions. And so we've already begun working with some physicians who actually do these procedures. And this is actually one of the cases, and it would be interesting to show you this case and the intervention that follows. So this fetal baby actually at mid gestation, so it's like growing normally till the halfway in its pregnancy, that you have the aorta being blocked, and the left ventricle over here is unable to contract because the outlet over here coming out of the plane is blocked. So, it cannot contract, and when you try to squeeze hard, it causes a regurgitation jet back to the atria. So you can see that jet here. So that's the left ventricle, and the squeezing flow back to the atria. All right. So, and for that reason, the atria is also pathologically enlarged. Now, if you look at the right ventricle, on the other hand, it's actually contracting quite well. Now, so this is the intervention that the physician would do. So they would stick a needle all the way through the mother into the fetal ventricle, and then they would insert the wire, the guide wire, and then the balloon through the obstructed aorta, and then they would balloon it so to relieve that blockage, and then they would check that the blockage is being relieved, and then they will retrieve the whole catheter-based setup. So then after that intervention, you can see that the ventricle contracts a bit better, and that the regurgitation jet coming downwards now is actually partially resolved, it's getting better. And by birth, this case actually succeeded, and you can see that the LV is now contracting very nicely and is of good size. Yeah. So we want to understand this a bit more, and in terms of why is it that in some cases it works better and in other cases it doesn't, and we want to be able to build tools that can predict, using our biomechanics tools that can predict what happens, whether before they intervene, we want to do that simulation and tell them yes, it's going to work, or no, it's not going to work. So if it's not going to work, maybe you don't want to do it, because every time you do it, you expose a lot of risk to that fetal baby, and there's a maybe 5% chance that the baby would die. Right, but and we want to be able to work together with doctors to advise them to that extent, and of course that work still ongoing. But from here, next step is to understand the disease, which is what we did here, is to model the disease a bit more closely. So we have also developed a finite element tool to be able to understand the stresses of the heart and its motion under the normal and disease condition. Here, this is a FE model, which is done with the Phoenix software. It's joined to a simple Windcastle model for now, which mimics the resistances and the compliances of the vascular system. But we will have a more comprehensive and a complex one being developed now. And we show that, we can get our heart to move in the right way as imaged. So here you have, I think the yellow color is our model, whereas the red color is segmented from our ultrasound image for both the N diastole and the N systole. So we show that we can kind of make it move in the right way. So a model has a active and passive stress, right? So the active stress is kind of the contraction of the heart. The passive stress is just the stiffness, which is modeled with appropriate 3D strain energy functions. And we have also a spatially varying fiber orientations, because we know that the fibers of the heart actually has a varying direction from the epicardium outside layer to the endocardium, the inside layer. So all those are in this model. And so we could model disease in terms of the obstruction of the outlet, by having an increase in the resistance in the Windcastle model for the outlet. And we can also model regurgitation back to the atria just by adding additional elements back to the atria. And so what we found here was that, when we have the stenosis, it typically raises the pressure by 10 to 20 milliliters mercury of pressure, but it can actually be quite severe, that it can cause the heart to hardly be able to pump any fluid out at all. You can reduce the stroke volume to almost near to zero, and its strain to be quite low. But but the velocity through the valve would not be low at that point, and they can still be quite high. And then with a bit of mitral regurgitation, you allow some of that pressure to relieve itself, and so you get some reduction in the LV pressure. And but the interesting thing is that we from our model, the velocities at the valve and the regurgitation were never quite high. They're always less than 3 meters per second. But in a lot of the cases that we measured, in the human fetal hearts with this obstruction in the aorta, is that they get regurgitation velocities of up to 3.4 meters per second, right? So, which means that when we have modeled the obstruction and the regurgitation without changing the anatomy of the heart, that's not enough. That's not strong enough, to give these velocities that we observe clinically. And that must mean that the wall has thickened. There's some kind of a hypertrophy that goes on, so that the heart becomes stronger and it's as it's tried to cope with its abnormal environment, which is quite typical of hearts. So we model that, and we model what happens if the heart thickens, undergo hypertrophies and thicken. And yeah, sure enough, we're able to get very high velocities, and we show that the thickening of the wall have a great effect on the function and the physiology of the heart. You can greatly increase those pressures, you can greatly increase the strains, and you reduce a bit of the stress that the muscles would feel. So it must mean that if our model without the thickening cannot reach the velocities that are observed clinically, it must mean that in these babies, they must have undergone some kind of a hypertrophy, and which is true. So when we actually measured, in some of these babies, what is their thickness of the wall, these diseased babies, the thickness of the wall compared to the normal ones, we saw that actually they were about twice as thick, which is kind of confirm our models. But then we try to, we also looked into what happens when you have a fibroelastosis. So a lot of these babies, when the aorta is kind of restricted, you have the inner lining of the heart being more echogenic. You can see it brighter on the ultrasound, and it's because they have growing a lot of fibers there. And doctors would all think that that is a bad thing. It kind of impedes the function. It prevents the heart from contracting maybe, and all these things. But in our model, we tried that, so we increased the stiffness of the heart by up to 100%, right? And it just didn't affect the function much. It didn't decrease the pressure much. It didn't change the strain much. It didn't change the stresses of the muscles much. So basically, we are forced to kind of conclude that no, that's not what happens. You might have the fibroelastosis, but it's not adverse to the cardiac function. It doesn't disrupt the heart's function. Rather, maybe it's just a byproduct of that disease because of the high pressure or different flow conditions. You have some fibrosis on the inner lining of the wall. One of the things that we estimated here was on the hypertrophy, the thickening of the wall. We found that there was 100% thickening of the wall on these diseased babies, right? But when that happened, when we modeled the 100% increase in the thickness, we get these pressures which are just off the charts. It's just really too high, right? And compared to there's a few measurements of the invasive measurements of these fetal hearts in that disease, and they can never match the kind of pressure that we are seeing. So it must mean that at the same time that the walls are thickening, they are also kind of weakening in those walls to kind of decrease down the function of the heart. So through this modeling work, we were able to kind of figure out things that are very difficult to observe clinically. It's very hard for the doctors to go in there to make those measurements and to do those what ifs tests. But using a model, based on the real clinical measurements, we can build this model and we can validate back with their data, and then we can use this to predict, to understand, to figure out some of these issues. And of course, we have not gone into actually looking at the intervention yet, but that's the next step. And I think that would be quite interesting, to try to understand what effects it has on the biomechanics and whether that's beneficial, and why is it that in some of the patients it worked and in others it didn't. So I just want to, I guess, so that's the future work here. And then I just want to spend one last minute to kind of show that we also have some work in the small animal embryo. So we've done quite a bit on the clinical side, and try to push that further to the next step. But at the same time, we are also trying to understand what are the embryonic, in the animal models, we can mess around with it. You cannot mess around with a human heart, but you can mess around with some of the embryonic hearts to understand why some of them get malformed. So this is one model that we have here. We use the chick embryo and we tie the left atria up, and it will give us the hypoplastic left heart syndrome. So kind of like we put a little knot on the left atria. And over the next few days, we actually develop a very small left heart and a much larger right heart. And then we can use ultrasound to scan it, and then we can build our models again to understand those flow that's going on in there and what has changed, right? One of the things that we have found was that, with this left atrial ligation animal model, there is a much more oscillatory and weaker washer stresses on the left free wall. So these particles will stay there for a long time, and they're very oscillatory. They just kind of bob around with the motion of the heart, and kind of slowly getting washed out because they're kind of further away from the main streams of the ventricular flow. And at the same time, we're also conducting some kind of sweeping all the genes and see what we can find, what could be responsible for the malgrowth of the heart when it's being disturbed by abnormal biomechanics. So we did some kind of a single cell RNA sequencing for this animal model, and we kind of laid down some plausible pathways where you can have the disruption of the flow stresses and the myocardial contractions affect some of the mechanical sensing factors, which then goes through a bunch of pathways and cross signaling to then cause the reduced proliferation, the fibrosis, and the lack of the contractile responses that we have observed in this model. So that's, however, it's a story for another day. I think we are kind of out of time, and I am very grateful. Thank you for everybody for coming and listening to us. That's it. Thank you. Of course, the real heroes behind this work are here, and of course the money also are the heroes here, and of course we have a lot of very prominent and excellent collaborators in all over the world, and we are expanding on that too. Thank you.
Thank you, Yap, for a fascinating talk. And so I would like to open up for the questions, but I haven't spotted any question written into the chat box. Not Yeah, not yet. And I understand you can hang about in the wine and the cheese session for 15 minutes or so past the hour, isn't it? So if that's the case, we might want to sort of shift to sort of direct mingling opportunities. I know that's much easier to ask questions and in general, so we could do that. Is there anybody who want to ask questions at the moment? Right, maybe not. So the because we have two speakers, we have to think about ways to hold the sort of a personalized question session virtually. And what we decided to do is that, so Yap will remain in this team's sort of gathering, and but for Parry, we are going to open up a virtual lounge in a platform called Wonder. So to enter that lounge, you will be asked to sort of input sort of three things, like your name, and they take your picture, and something like that, and then you can go into the lounge. No password required, and she will be there. And it's a kind of a lounge software that you can go in, and when you go close to somebody, that then suddenly your microphone and the video turns on, and then the people nearby can hear and see you. And so it's a little bit closer to what happens in the actual physical lounge. So we invite you, if you would like to talk with Parry, please go into the site that I just posted the link. And yes, and if you want to ask questions to Yap, please remain on this Teams meeting. And thank you. I would like to thank two speakers today for fantastic talk, fascinating, and it was so great to hear about what they are working on now, but also their future directions as well. And there are already quite exciting things happening in the department, even though they just got here. And I know, Yap, you are also developing exciting collaboration already with the people in the department. So it was really, really nice to hear about. And yes, I hope you can have a nice nice little gatherings to get to know them even further as well. So thank you very much for coming to this seminar, and see you in Wonder Room, or please stay on this chat.
Thank you, Naomi.
Thanks. See you. Bye.
Thanks, Naomi.